Hi, everybody. Welcome to the VTC Wellness Medicine Journal Club. This is December 24, covering the updated 2024 WMS spinal cord protection guidelines. Going to add in some TBI discussion, work through some cases and kind of real life examples as well. This is the last session in the, the eighth series. So I'll be sending out FOM certificates after I look over participation for the past 6 months. So expect those sometime this month and the next. And then we'll move into series 9 starting this January. So it's coming up pretty soon. Just expect give me a couple weeks to go through everything, but I'll get those out to you soon. That being said, Jackson, when you are ready, take it away and we'll start spinal cord protection.
All right.
One last thing, sorry. If you have your name as some like says iPhone, I'm not going to know who you are. So please make it your full name. That like, let's see it just in this example, Ian. Could you add your last name? I don't know how many Ians there's going to be, but it might
Yeah,
just be
no, no
easier
problem.
if you
Thank you.
want. Just as an example, you're the one of 7 on my screen. Anyway, take it away.
Cool. Can you guys see okay? Yeah.
Yep, it looks good.
Cool. Sounds good. All right. I'm Jackson. I am a second year resident here at UT Southwestern in Dallas, Texas. I'm going to be presenting the Wilderness Medical Society clinical practice guidelines for spinal cord protection. And I think I was kind of laughing when I realized that Dr. Hawkins is going to be here today because I was like, I guess I'm presenting his guidelines to him. So appreciate you being here. But um, without further ado, I can kind of jump into it. So, just a little bit of background on spinal cord injury. There's about 54 cases per 1 million people per year, at least in the United States. The majority are MVC related, then falls about 32%, violence about 14%, and then kind of other causes that last 16. There's been a lot of improvements in terms of like the number of cases per year since like about the 1970s, 1980s, with seatbelts becoming required in automobiles. Previously, it was a lot more common to see pretty gnarly spinal cord injuries from MVCs. Those numbers have gone down a lot now. So that's a little bit of background. So as far as wilderness medicine guidelines go, the managing these kind of spinal injuries in a wilderness setting is much different than managing them anywhere else. I'm sure we've all been in an ED somewhere where every MVC patient comes in with a C collar on and some type of immobilization because that is how our urban EMS is taught, especially when they're 5 or 10 minutes away from a hospital. But it's very different when you're in a wilderness environment in terms of things like it's going to prolong your extrication time. It's going to make it a lot more difficult and complex to perform any type of rescue operations. So your logistics of performing operations is going to be much different, and it's going to have a lot higher of a financial cost. And then the other thing that's very interesting is it actually has an increased morbidity and mortality for not only patients but also providers, because you have to think about how you're expending resources and how your providers are going to be extricating people, and if they're carrying a litter with with someone over some very difficult terrain, there's a lot of risk for provider harm there. So they're big things to take into account when you're considering specifically wilderness environments. So the big goal with spinal cord protection and spinal cord precautions is to minimize the risk of missing or exacerbating a potentially unstable spinal injury. It's not to totally immobilize the spine. It is to to basically make sure that you're not going to exacerbate any underlying injury, and that's the big goal that they stressed here in the guidelines. So the methods that they went through to develop these guidelines, they were originally developed in 2011, and then I think they've gone through them multiple times over the years to update them. The last update was this year. The panel includes an orthopedic surgeon, an EMS physician, a tactical kind of military physician, a wilderness EMT, two paramedics, and a sports medicine physician. And then they went through a bunch of different papers using, I believe it was PubMed and one of the other search engines, and then also relayed this with their own experience, their own patient care experience, and then case studies that they had found as well to develop the protocols here. So first things we'll go into, and this is, and I organize this a little bit differently than the paper, just because it made sense to me to group some of like the cervical spine things together, so it doesn't follow exactly with the paper if you took a look at it. But the first thing I'll touch on here is positioning. So at the end of the day, the big recommendations that they discussed were maintaining the spine in a neutral alignment, and in terms of if you have to do any airway access, any airway adjuncts, it's preferable to do a jaw thrust than a head tilt chin lift because it keeps that cervical spine in a more neutral position when you're doing the jaw thrust versus the head tilt chin lift to help kind of minimize exacerbating potential injuries. And then something that you're going to see here stressed a lot, but this is kind of the initial time I'll say it, is using non-rigid tools during extrication is key. So from there, in terms of moving the patient and positioning them that way, what they recommended is a trap squeeze technique, which is what you see in the picture here, which is, I think, something we're all pretty comfortable with, or I'm sure we've all done this in the emergency room, which is essentially getting the patient between your forearms and kind of holding the head there with your hands overlying the patient's like they're kind of over their shoulders versus holding their head itself. And then what they also recommended is if you're having to transfer the patient, is having someone hold that C spine and then lift and slide to transfer versus doing a log roll, which we're all which we see commonly in the emergency department, but there's a little bit lower risk with that lift and slide for potential injuries. And then the other thing that they discussed was if you're concerned about airway compromise, facial fractures, unconscious patients, people where you're not sure if they're protecting their airway or they might have an underlying reason where you're concerned about the airway, you can potentially position them in the left lateral decubitus position to make sure that stays patent. So then, when we're talking about cervical spine immobilization specifically, there's very limited evidence that shows that cervical collars are effective in field management, and very little evidence showing that they have any improved neurologic outcomes. And the type of cervical collar used doesn't affect the type of cervical collar used does not affect neurologic outcomes or decrease motion. They had a lot of very interesting cadaver studies and patient studies where they were placing essentially motion sensitive probes on patients to see how much motion, or to see essentially how much spinal motion there was during extrications with an automobile and with transferring the patient on different types of backboards. And they didn't really see much of a difference here in terms of the different cervical collar use. And that will lead us into some later points here. But when we're discussing cervical spine immobilization, the big things that we're going to be using, and we use these in the hospital, but additionally, it's very important to use them in a pre-hospital setting, is utilizing your Nexus or Canadian C-spine rules. Canadian C-spine tends to be a little bit more sensitive, but either of the rules are pretty easy to use and should be kind of the go-to. But when it comes to actually putting on the splint, I discussed that non-rigid collars are ideal, and that's what the recommendation is. And so when I say non-rigid collars, we're talking about things like a soft neck collar or a vacuum splint. And when I say vacuum splint, because I've never seen it used this way before in a hospital setting, but if you've ever seen a fracture, like a femur fracture, lower extremity fracture, where they have that orange, here for us, it's kind of an orange, weird looking like a vacuum, it's a weird looking splint that they've essentially just kind of sucked the air out of that form fits around the legs. It's the same concept, but you put it around the head and it form fits the head into that position so that it's holding it in place, but it's not rigid. Because the use of rigid collars actually potentially can increase your morbidity and mortality, which I'll kind of touch on in a little bit here. Um, so when you're extricating patients with these C-spine injuries, big things are you're reducing passive neck motion and allowing patients self-extrication. So a lot of this is really, the big thing here is patient education is very key. So you're educating the patient on trying to reduce that passive neck motion, talking to them about potential injuries and talking to them about how important it is to reduce motion, but also allowing self-extrication, which was a really interesting thing to read and read through some of the studies that they mentioned in this paper, because basically the outcomes are improved for potential spinal injuries, or not improved outcomes so much as, I guess, it's reduced motion to the spine when they're using those sensors that I talked about earlier, if you're letting the patient extricate versus if you're pulling them out of a vehicle on a backboard. And so, again, if you get to the point where you can't allow self-extrication because of extensive injuries, again, I'll keep harping on this, you're extricating and packaging the cervical spine without any rigid collar. So again, with that soft collar or that vacuum splinting. So to touch on kind of a little bit more of this is, so discussing the effectiveness of spinal immobilization and reducing neurologic sequela. So they did not find a single study that in which they saw worsening of neurologic symptoms due to EMS extrication, but they did see studies that showed that there were potentially injuries from immobilization itself. So we're talking about immobilization increasing morbidity and mortality. Some of that can be due to patient discomfort, and patients tend to move around and tend to exacerbate further injuries due to discomfort. Some of it tends to be because of airway issues and masking of underlying conditions that you're not going to be able to see when you're fully immobilizing the spine or immobilizing the cervical spine. But that goes to say that their recommendations at the end of the day were that spinal cord precaution should be considered with an actual or suspected injury. But if you have a low suspicion for an injury in a wilderness environment, it's much more important to allow that self-extrication and just talk through, reducing that passive motion of the spine with the patient. And spinal motion restriction is the safest and most effective means of spinal cord precautions. That's in contrast to full immobilization, where you have someone on a backboard, you're strapping them down and making sure they're not moving, which again has been shown to increase morbidity and mortality. So this is the full vacuum mattress. So in contrast to a traditional backboard, it provides superior spine stability and motion restriction, and it's easy to use, quick to put on. I think that they did show that for providers in the field, it took a few more seconds to put on this vacuum mattress than a backboard, most likely because people aren't as familiar with using it. But again, it was a matter of seconds, which I think the benefit outweighs the risk here, because again, improves stability and motion restriction, and it's great for patient comfort and will overall improve your outcome in terms of getting your patient extricated. So the other thing that they touched on here was how to manage penetrating trauma, so penetrating spinal injuries. And it's very key here. And the big takeaway is do not immobilize these patients. Do not immobilize patients with an isolated penetrating trauma because of things like masking a tracheal deviation, masking an expanding hematoma underneath a cervical collar. And then it's very difficult to assess a carotid pulse correctly if it's under the C collar. And then additionally, if you do have to go ahead with airway adjuncts, it can greatly affect your ability to intubate. And I'm sure kind of we've all been there before where you're intubating someone in a C collar and you have very limited spinal motion. It makes it a lot more difficult. So for these patients, it's very important to not immobilize them so that you can effectively manage their airway and effectively manage any underlying conditions. So, big take home points with the guidelines here is there's absolutely no role for rigid backboards or rigid seat collars in a wilderness environment. And if a patient is suspected of having a serious spinal injury, it's probably more important that they're not immobilized and that we do some of this patient education and really think about how we're going to be extricating them, the risks that we're taking as providers, and the risks to the patient if we do potentially undergo some spinal precautions while avoiding that immobilization. And then all patients with any evidence of a neurologic deficit should have spinal cord precautions implemented. But again, avoiding that total immobilization because you're probably going to increase morbidity and mortality of the patient and yourself. So that's all I have here for my slideshow, at least. But happy to answer any questions or hear from Dr. Hawkins.
Great job. That was very concise. Definitely did a good job preparing. I see Dr. Valdivia has his hand raised. Do you have a comment or question, Dr. Valdivia?
Yeah. Hey, how are you, Justin? Yeah, call me Juan. Hey, nice presentation. Um, I'm just curious as to um how they come up with that recommendation of avoiding rigid immobilization because in from the surgical standpoint, that's what I do. Yeah, is extremely important to immobilize patients, especially if a patient that is complaining of neck pain after a car crash or falling from a mountain or something. I happened to be a firefighter in my prior life when I was a med student, so I saw those patients. But I'm surprised to see that the push is against a rigid collar, where let's say in the surgical world, where we see spinal cord injury or even without spinal cord injury, spinal trauma more than one or two columns, we do rigid immobilization, even definitely post-op or post-op patients as well. I wonder if they do any difference between patients that are conscious or unconscious, and if a conscious patient that is awake, alert, and oriented is telling you they have severe neck pain after a trauma in the wilderness, would you still not use rigid collar, or would you use clinical judgment and use rigid collar?
I'm gonna leave that to Dr. Hawkins a little bit to go into a little bit more detail.
Yeah, that's great. Juan, it's great to meet you. And that was a fantastic presentation, Jackson. And I completely agree with you, Juan. This is, especially coming from a fire background, this is probably the biggest change I've seen in trauma in our lifetimes. And what it's really come about from, like Jackson was emphasizing, is just the utter lack of evidence that we can find of pre-hospital benefit to immobilization, with a growing number of cases where bad outcomes are attributed specifically to the immobilization action. So um, and I agree with you. The surgeons, I think, are the ones who are most reluctant to go in this direction. So we've seen nationally and internationally, ICAR is adopting these recommendations. The Wilderness Medical Society has, National Association of EMS Physicians, the American College, the American College of Emergency Physicians. Now, in the most recent kind of unified guidelines, American College of Pediatrics, it's the American College of Surgeons Committee on Trauma that I think is very reluctant. And I think you're right. The standard remains post-surgically to use collars in this case, which is a different population than traumatized patients in the field. So really, I think the pivot point where things started to change was around 2012 to 2017. I know in 2016, we stopped using backboards in my county. in North Carolina. Now more counties than not, from an EMS standpoint, do not use backboards. I think nationally that's rapidly evolving. Much of Canada, large parts of Europe no longer use backboards. So in a way, we've been doing kind of the big public health experiment to see, are there going to be, like a large jump in cases or all these published incidents where a lack of immobilization has resulted in bad outcomes. And again, we're not seeing that either. What we'd really like to do is get, a controlled trial where Mondays, Wednesdays, Fridays we immobilize, Tuesdays, Thursdays, Saturdays we don't, and we see what the outcomes are. I think the conviction you're describing about the importance of this was why we could never really get IRB studies approved to do it. So in this case, just seeing the evidence that we've seen, a lot of wilderness and EMS physicians have chosen to follow that evidence that's available. So that's, I think, where we got here. I think in the context of conscious and unconscious patients, certainly if a conscious patient says they have pain in the neck, then the message that's usually promoted is don't move your neck in painful ways, which kind of makes sense. And then the packaging that's recommended is designed to reduce motion as well. So it's not a nihilistic proposition that nothing is done. Most or many EMS response agencies in wilderness areas aren't equipped with rigid collars. We spent a lot of time trying to replicate them. Huge amount of wilderness medicine classes were sort of spent teaching that, and success was considered to be how closely it came to actually immobilizing the C-spine, which increasingly people are thinking may not be the real goal. The real goal is non-physiological, painful, or damaging movement, which can be accomplished with a vacuum splint or the soft collar, probably equally as well based on the data, like based on the evidence that we can see, like Jackson was describing, of actual movement in those tools. And a rigid cervical collar actually doesn't do a great job of completely immobilizing the neck anyway, although it has lots of complications and potential problems. If somebody's unconscious, again, the intent with everything about trauma would be to reduce unnecessary motion, which is why we package patients for movement in a wilderness setting if they're unconscious and they've been traumatized. Backboards are probably the worst idea there in a wilderness setting, because you could be on that tool, whatever you're using to move a patient, for hours and sometimes overnight. And for sure, there'll be complications from that with no apparent benefit. So that's a lot of talking, but I agree with you. This is a huge change. It's been evolving really for the last 10 years. We've had the initial data that Jackson was talking about really since the turn of the century. It's sometimes being pointed now to, and there's been some publications around this, about one of the examples of how evidence changes things and how slow that can be. Often it's 10, 15, 20 years before practice changes with evidence, particularly in things like this that are such ubiquitous training. So like you said, from the fire perspective, we've trained successfully an entire generation or more of first aiders, first responders, EMTs, paramedics, lay people to think that holding the head immobile is the absolute necessary first step, really with actually zero evidence that that's ever been shown to have a difference in outcome to it not being done, or to just general reduction of motion and non-physiological, non-painful reduction of motion. So it's a little bit of a perspective. Jackson, you did an awesome job. And one, I agree with you, this is really challenging. And I think, the attempt to kind of change things here, whether it's warranted or not, is one of the biggest changes in trauma that we'll probably see in our lifetime.
We still have a huge stack of backboards out in the back of my hospital, and I was just staring at them the other day after going through this paper, kind of wondering.
I would say,
no, sorry, go ahead.
I was just going to say really quickly that there's this, even now having this just come out, there's a much bigger, just so everybody knows, there's a much bigger analysis coming out from that combined group of NAMSP, ACP, the American College of Surgeons Committee on Trauma, and ACEP, and that's now in the peer review stage. So that's going to be a much bigger body of organizations that are kind of weighing in on this, and it'll be interesting to see where they come. The original statements that they made um, were discouraging of backboards, more encouraging for rigid cervical collars. A lot of places still use rigid cervical collars, like North Carolina still does. So that's been much slower to change than rigid backboards.
I think one of the most important things I see it just in the ER setting, or let's just say inpatient in hospital setting, is and Jackson, you mentioned it pretty early on, is the actual approach to holding C-spine. First year residents, students, and almost every nurse I see in the department will basically grab the ears and think that they're in any way providing any protection whatsoever. So just remember to teach people, if your goal is protecting or mobilizing the C-spine, then at least approach it in a way that makes sense. So yeah, you like a crab, you kind of squeeze the traps, and then I just kind of use the forearms to support and hold. And that way you have like a fulcrum here as you're in line with the patient rather than just cranking on the neck. And I've seen that in any of the, ATLS courses I've been in, any of the AWLS courses I've been in or taught, and in hospital on scene, like it's pretty interesting. So at least you can, if your goal is immobilization or protection, at least manage that correctly, and make sure you see it. We usually, when we transition from stretcher to bed in the trauma bay, that's when it comes into play. And, it's a high stakes setting. You've got the ER team who's basically doing ABC, or at least airway. And then you've got the rest of the team focused on everything else, and there's not much communication all the time. So just make sure somebody at the head of the bed is at least focused on that. But any questions, concerns based on anything else we've seen? Juan, I see your hand raised back up.
No, that's great insights. I wonder what is, you must know this more than me, but what is the legal stance on this particular topic? Because at least in Florida, this business of car accidents is so rampant that you see a car accident and then 20 lawyers will be like knocking on the victim's door, and they're asking, did they put a collar on? Did they put a collar on? So I wonder where they stand, because where they stand it's important for us. I wonder if those guidelines are accepted by that medical legal community or not. We'll be curious,
Jackson, I'm happy to try to take that, or I would love to hear what you think too.
I would imagine you'd probably approach that with the same way we kind of discussed earlier, just discussing that there's not really a lot of evidence to support the use of the backboard in a legal setting, but I could very easily see lawyers taking those types of cases to try to argue against it, and then it becoming a whole battle.
Just know that in any lawsuit, the defense and the prosecution will find a physician who will support their side. No matter what the case is, they will find supporters for both sides.
And especially in this case, because there's such an interesting range of experience and opinion on this. So there's very traditional approaches, and then there are these much more progressive or newer ones. Juan, you are spot on so when we changed our protocol in my county in rural and wilderness North Carolina, we have an interstate going through it, and I was scared of shit. I was the first medical director in North Carolina to change to a non-backboard policy, and I was certain we were going to be sued, or have some orthopedist or neurosurgeon driving by on the interstate and see somebody taken out of a car. So nothing happened. There have not been legal outcomes that we're aware of that are egregious. However, what many of us have recognized is one of the reasons why it is 15 years or more for practices to change is that there's a standard of care and there's fear about legal action. And that is a very, very pervasive, compelling, meaningful thing for wilderness response teams, is they there's the evidence, but then there's also what the standard of care is, and there's a lot of fear about legal action. What I and many other people who've been looking at this for a while are afraid of is actually the alternative. So with the amount of evidence that has been gathered about the harm from these interventions, the lack of any available evidence of benefit, that Jackson was emphasizing, a smart lawyer seeing that I would think would love to go after somebody once these guidelines start coming into place. So once there are these consensus guidelines and then these population-based studies that are arguing against immobilization, should somebody have a bad outcome, especially one that might be expected, like pressure sores leading to sepsis or airway issues from a backboard, it would be I would feel very bad for the physician trying to defend themselves, because just like we said, there will be both sides, but the things that are brought to bear and you could put up in a courtroom that are evidence-based, consensus-based, professional guidelines society-based, that argue against the use of these tools are pretty compelling along with the evidence. And it would be pretty much on the side of defending the use of them would be standard of care. That would be, the one thing which has always kind of kept this going. And in the face of somebody who had a known bad outcome that could be predicted by one of these tools, I'd hate to be that person on the stand.
And just as most participants here in general, based on history, are students and residents, just remember this is somewhat newer things as you're getting through this discussion. So this is great to know on shift. It's great to discuss with your attendings and the trauma team, neurosurgery team. If it's your hospital policy, if your trauma surgery policy, your attendings policy, do what they say. Our goal here is for you to not get in trouble. Just know that if you can bring this up, you can make this a discussion point in a positive way.
If I could expand that too, that's true for the wilderness. So you could go to courses, you can learn all the evidence or lack of evidence, you can learn all this. My wilderness response teams in North Carolina use rigid cervical collars, or at least collaborate with EMS teams that do, because that's a state protocol. So once you're practicing, regulated medicine and you're working on a team and as a team member, it's great to have this dialogue. It is not standing over the patient debating. If there's a protocol in place, the best approach, especially from a wilderness setting, is offline, not during an operation, unless you feel like there's some direct threat. Talking to medical directors or people doing it. A very common interface we see in the wilderness setting is handing off care. So it could be that a wilderness team that follows newer protocols and doesn't use a backboard hands care over to maybe an ambulance-based team or a front country team that puts them immediately on a backboard, which, if that's their protocol, that is the way they should go. And the time to debate that is not on the scene.
I think another thing I see somewhat often in the ER is a lot of the times patients will come in from a scene response with a rigid collar on, and they're somewhat agitated, whether inebriated, whether they have a TBI, and that's why they're altered. But then they're thrashing around, they're ripping at their collar. So weigh pros and cons when you put on a collar. I suppose you could just intubate them, but it depends on how cowboy of an attending you've got. But yeah, it's one of the worst things is when you have a patient who this collar is making them more altered or making them more agitated, move more. And otherwise they could maybe be redirectable and sit there. So weigh pros and cons, but otherwise just follow what your protocol is. But any other questions about spinal cord protection? And I think we could potentially move on towards the TCCC and TBI, unless Seth, you want to go through the cases now. Do the TBI.
Yep, that sounds great.
All right, great job, Jackson. Thanks for prepping so much. And then Sally, I saw you on here somewhere. There she is. Hey, Sally, take it away.
All right. Well, I'm going to get this pulled up, but just for context, I'm an orthopedic surgery resident, and your article caused a very lively lunchtime discussion at a clinic today. I work with some very opinionated spine surgeons. So, all right, let's get this in presentation.
That's to be expected.
Absolutely to be expected. It was,
Right.
I can read the literature and understand it, but then it's still hard to reconcile it with knowing what the scans can look like underneath the skin, and knowing what we've seen before with some of our traumas. All right, can everyone see my screen?
Yes.
Perfect. All right, so let's talk about these TCCC guidelines. So the goal of the study was to translate lessons learned from the combat sphere into other austere settings, because just like the battlefield, we see a lot of traumatic events and traumatic events with TBIs in the wilderness. And we're faced by similar, not dissimilar constraints in resources. So TBIs occur in traumatic events in the wilderness, not infrequently. Incidence ranges from anywhere from 5 to 50% of the time. And these are typically from falls during mountaineering activities, but really any fall from height, high-speed crash on bikes or skis, or watercraft can cause this type of injury. In the military, rapid evacuation is going to be your standard of care, and they have the infrastructure to support that, but it's frequently not possible in a wilderness environment. Air medical evacuation can take a while to set up, and frequently you may be faced with a ground evacuation. However, there are field diagnostic and treatment modalities between the two spheres that are very similar, and can take what we typically think of in the front country as a ED or even ICU level problem and point out that we really can manage these in the field with a degree of effectiveness. So just going into some definitions first, so we're all on the same page. There's two main ways that we can define TBIs, both based on the Glasgow-Coma scale, so our GCS classification, and also pathoanatomic classifications that describe what is actually going on at the structure level in the brain, whether these be subdural hematomas, epidural, subarachnoids, cerebral contusions, different sexual injuries, or some combination thereof. And I think intraper ankle hemorrhages, I didn't mention those either. So moving into TBIs. TBIs are defined as a trauma-induced physiologic disruption of brain function. And this is represented by one or more of the following occurrences: loss of consciousness, a loss of memory, altered mental status, or a focal neurologic deficit. The vast majority of these are mild. Many of these can be considered concussions. And they have the following features: no loss of consciousness or a loss of consciousness less than 30 minutes, an initial GCS of 13 to 15, and a short duration of post-traumatic amnesia. You can break up the mild TBIs further into grades 1, 2, and 3 based on the level of loss of consciousness and the duration of symptoms. Moderate TBIs have a loss of consciousness anywhere from 30 minutes to 24 hours with a more substantial neurologic deficit, whereas a severe TBI is defined as a loss of consciousness greater than 24 hours and a very severe neurologic deficit of the GCS of less than 9. We use the GCS as our primary scoring system in front country hospital-based medicine. It's a little bit more complicated, and it has been shown to be predictive of long-term outcomes. However, this can be affected by other things going on in a trauma scenario: shock, acute mountain sickness, or PACE, drugs, other injuries, and many other factors. So there's EMS level scoring systems that have shown to be almost as accurate in the backcountry. So you can use ABPU score, which grades a patient's response. So they're either alert, responding to verbal stimuli, responding to pain, or they're unresponsive, matching up to the verbal component of the GCS scale. There's also the best motor score. It's another less cumbersome assessment that looks at what kinds of commands the patient is able to follow, or are they posturing, or how they're moving in response to pain, similar to the motor aspect of the GCS scale. And when you pair best motor with pupillary reaction, you can generally predict underlying injury, and it has some prognostic features as well. And then the last thing before we get into management is secondary injuries. These are defined as non-mechanical damage that occurs after the primary injury. And this can be exacerbated by a number of factors that occur after the traumatic injury has occurred. And this is where we really have an opportunity to intervene as care providers in the outcome of these patients. So the first thing we need to talk about is cerebral perfusion pressure. So CPP is defined as the mean arterial pressure minus the intracranial pressure. CPP should generally be greater than 60, and we have other goals for MAP and ICP, a goal MAP of greater than 60, and pardon my typos, ICP should be kept less than 20. There are several signs of increasing intracranial pressure because we are not able to monitor this outside of the hospital setting. I don't know about you, but I don't plan on putting any bolts in the wilderness. The signs of increased ICP can include decreased level of consciousness, any sort of motor posturing or lateralizing signs, asymmetric pupils, hemiparesis, so that's more of a signs of impending herniation. Secondary injuries can also be caused by another number of other factors, so hypotension, hypoxia, hypo or hyperventilation, as well as hyperthermia. Specifically, hyperventilation can lead to cerebral vasoconstriction and subsequent brain ischemia. This is definitely something that we want to avoid. Hyperthermia has also been demonstrated to be harmful, but in the initial care phase, hypothermia for us as providers in the wilderness is going to be actually more detrimental in the acute phase. So let's move on to management. So our initial evaluation is going to be much the same as any other traumatic patient. We're going to make sure our scene is safe. A lot of these are high energy events. We need to make sure that if our patient has fallen from a height, that we are able to safely get them down to a point where we are not creating a situation where our rescuer is going to get injured. The ABCs in the primary survey are of course necessary. And thank you, Jackson, for your presentation on spinal cord protection, because many head injuries in the wilderness are associated with spine injury. So that needs to play into your evaluation of a patient with a suspected TBI. In addition to vital signs, your primary survey for other injuries, and stabilize any life threats, the assessment of a patient with a suspected TBI needs to include the level of consciousness and lateralizing signs, and then a pupillary exam for both pupil size, symmetry, and reactivity. We also need to be able to monitor vital signs. In some settings, you'll be responding with a wilderness EMS agency. You may have the capability to measure O2 sets, capnography, have a blood pressure cuff, have a glucose monitor. But even for someone who doesn't have any monitoring equipment with them, we can all keep track of our patient's pulse, respirations, and track their neuro exam. Beyond that, we should be reevaluating vital signs in a trauma patient like this every 5 minutes. And there are goals outlined by the TCCC for what those metrics should look like for someone who's not doesn't have access to monitoring equipment. Our main criteria here is going to be keeping track of the pulse and keeping track of the respirations and tracking that neuro exam every 5 minutes. So our goal here is to maintain the vital signs and maintain normothermia, because hypothermia can be very harmful in the acute phase. Another thing to keep an eye on is pain control. These are traumatic injuries, and patients may have other injuries that require pain control, because those could get in the way of your exam. You do need to give pain medication. Ketamine is actually preferred in these situations. It helps maintain airway reflex and ventilation. It also doesn't induce hypotension. When looking at a trauma patient with a suspected TBI, we want to keep our MAP greater than 60, our systolic blood pressure greater than 100. And if you don't have the ability to measure either of those things, you don't have your blood pressure cuff with you, looking for an absent radial pulse. The presence of a radial pulse generally correlates to a systolic blood pressure of at least 90. If you lose that radial pulse, you know you need to get that blood pressure up. If you have IV fluids, please give them, but otherwise elevate the legs to increase venous return to the core, and that can help with perfusion. Then the next thing that we want to look at is our signs of impending herniation or increased intracranial pressure. So one, keeping the MAP greater than 60 is going to help with our cerebral perfusion pressure, but the other thing we need to monitor for other things that we can do is temporary hyperventilation. So temporary hyperventilation, so aiming at a PaCO2 of 30 to 35 for someone who has capnography, or a respiratory rate of 16 for someone that you're bagging, can help to decrease intracranial pressure. A 250 cc bolus of hypertonic saline can also be administered in this situation. You can also elevate the head of the bed or the head of the patient to greater than 30 degrees as another means of decreasing ICP. Of course, this needs to be done in conjunction, done with consideration to the patient's other injuries. Somewhere around this point, you should begin planning your evacuation. If you have a moderate or severe TBI, you should be immediate urgent evacuation by air. Those balls should be rolling already. For a patient with a mild TBI who has returned to their baseline mental status, this is someone that you could consider a ground evacuation for. But any patient who sustains a TBI in the wilderness is going to need a medical evaluation. So these recommendations are all coming from work done by the TCCC, a branch within the American College of Surgeons Committee on Trauma, for their military spheres, but they definitely apply out here in the wilderness settings. And the lessons that they've learned from managing combat TBIs in low resource situations definitely translate to our wilderness environment. The field diagnostic and treatment modalities that we have with us can be used to evaluate and treat the primary injury while minimizing any secondary insults for brain from hypoxia, hypotension, or increased ICP. And just remember that all TBIs, even if they are mild and resolved, will need medical evaluation, but absolutely expedite the extrication of anyone who has a severe TBI. That is all I have. Welcome for any questions or comments about the guidelines.
Oh, great job. That article was from 2017. I looked far and wide trying to find another TCCC that's more updated than that wasn't just part of a course. So that's why that one's from 2017. I usually try to keep things more updated. Any questions or comments? Sorry to double ask what she just said. Any questions about how to put those two together, TBI and spinal cord protection? They kind of go hand in hand, which is why I included both.
So one of the things I really appreciated about this article and the way that it was written is it offered solutions to patient monitoring and evaluating patient concerns that apply to both a wilderness EMS agency who's going into the field with patient monitoring equipment, IV fluids, IV access, hypertonic saline, all of these meds, but also addressed what you can do if you just have your day pack with you, which I think it was a nice lesson to see how just basic interventions and basic monitoring can help intervene in these very challenging situations.
Juan, I see your hand raised up.
Yeah, no, that was a very good presentation. I just wanted to comment on what you mentioned about pain control with ketamine. I'm just a little scared about ketamine because ketamine has a side effect of dissociation. And I've seen patients with ketamine post-op. You'll ask them to move your toes, and patients won't be moving toes. So, you have ketamine-induced conversion disorder or dissociation, where you ask the patient to squeeze your hand or give your motor exam, and you have no motor response, but will be ketamine-induced. So I don't know. I would be careful with that. And the other point is that you mentioned that patients with mild TBI could walk out of the field. I feel like any of those patients, depending on the mechanism, should have some prompt follow-up because epidural hematomas can evolve over 12 hours, 24 hours, and definitely subdural hematomas in patients over 65. They can evolve and create midline shift in a week, even without medical supervision. So they may show up back in the ER with massive subacute subdural hematoma. I feel like all those patients should have some follow-up within 48 hours. So
Absolutely. The authors mentioned ketamine as an adjunct to something that it doesn't have respiratory depression in the wilderness. And I know there's ongoing conversation about backcountry pain control, contrasting opiates versus other non-opioid analgesics. So it's a complicated discussion. Um,
Yeah, I've really not been doing this for too long, but ketamine has been quite the craze, at least in the past, I'd say 5 years. My time before that, it was kind of like the generic approach to pain control, pre-ketamine, I'll call it. I went to the ASAP leadership conference back in 2018, I think, in DC, and like we met with congressmen, and the whole deal was trying to advocate for more support for non-narcotic pain medications. And since then, ER and I suppose EMS somewhat because it branches off at ER has really shifted towards ketamine. However, I've also just this past week I just saw an EMS crew underdose it. So for any of the non-attendings in the room, what happens when you kind of underdose your ketamine when your goal is pain dose? So there's like 3 different phases, right, of ketamine as far as dose dependency goes. Kind of like kratom.
I mean, if you underdose that pain, if you underdose your pain dose, don't you get them to a little bit of a kind of like more of a dissociative
Yeah.
effect where they're
So
going to
if you
start?
don't give enough, if your goal is pain control and you don't give a weight appropriate dose, then you take this patient and now you dissociate them. If you give, I mean, there's a hefty range. It's like 1 to 3 mg per kg is a safe pain dose range. The difficulty is estimating. So, like every time you stand at the foot of the bed about to, well, now as an attending, I stand at the foot for the codes, but you're the whole team's like, well, what do you think that patient weighs? And everybody gives it wide variety. 0.1, sorry. So like weight base can really change things. So I just had this 18-year-old who had a tib fib fracture, just going up for a rebound. EMS drastically underdosed him, so he came in screaming in pain and dissociated. So that was fun. Um, and then I just like gave him the remainder to get to pain dose. So I think they gave like 0.05 or something. I was like, I don't know why you gave that little. So I gave like 0.15 to reach mg per kg to reach the 0.2-ish. And if you give too much, then they're like, those should protect their airway, but then they'll get like procedural sedation level. So just keep that in mind with ketamine.
That's Justin. This is
Go
Doug.
ahead.
Hey,
Hey,
the
Doug.
pain dose is the low. Hey, the pain dose is the lowest dose. The party dose, which is where you get sort of agitated, is in between that and the dissociative dose. In Maryland, we use 0.2 milligram per kilogram as the pain dose, and we go a lot higher for the dissociative dose. We never want to get in the party dose because that's when people are wild and out of control. I have seen patients that have gotten the pain dose that did get at least mildly dissociated, never severely. They get a little high, they get a little confused. But if you underdose the pain dose, then it's just not effective in my experience.
What was weird because my kid was yeah, he was out there, but
Yeah,
just writhing in pain still. So if you're used to it, go for it. But yeah, if you're worried about um altering level of consciousness, then yeah.
yeah. And the concern about dissociating the patient in the wilderness. I mean, okay, you want to follow a neuro exam, but you need to extricate them, and
Yeah.
that's probably the more important thing. In the pre-hospital phase, where I work, I'm starting an RSI program, and the state requires we have succinylcholine, but I prefer rocuronium because the
Mhm.
neuro exam isn't going to matter initially. We need to control the patient and transport the patient. The neuro exam later, is important, but in the pre-hospital phase, and certainly in the wilderness phase, I think you need to really get the patient out.
Yeah. Like it depends on your goal, it depends on the timeline where you're at.
Right, but when we're in the wilderness phase, we need to safely transport the patient. That's
Mm.
like that's the key thing, I think.
It's also tough when I've had a neurologist without telling the nurse, without telling the resident or the attending, just pause propofol infusions to do a sedation and then like not turn it back on and leave the room. So sometimes things get a little weird. So just in general, like everybody's mentioning here, just constant reassessment. Sorry about the dose mistake I mentioned earlier.
That's all good.
All right. Anything else relating to TBI and spinal cord protection? I just see a comment from Alan. That's tough. As long as somebody has a calculator they have on their phone or like familiar with adjusting for ideal body weight, they should be okay. But yeah, in general, meds should be based on ideal size. Same thing with sepsis fluids, by the way. Hey, Pierce, I see your hand raised.
Hey, how's it going? Can you hear me okay?
Yep.
Great. So there's been just a couple comments. Really great presentations, by the way. This is Pierce Beisinger, and I'm sort of new to the Roanoke, Virginia area from the West Coast. But one thing to think about in your ketamine discussion is a lot of times in the wilderness, if you're in front country medicine and you're used to dosing ketamine at the IV levels, and you're not doing that in the backcountry environment, you need to be if you're thinking about giving it intramuscular, just be familiar with the fairly significant dosing for intramuscular. So that's one consideration. I work with a guy by the last name of Van Tilburg on a Portland Mountain Rescue, and we've been bringing ketamine into the intramuscular utilization when we're just loading them up in a litter and bringing them off Mount Hood. And in that environment, we're sometimes going through Gore-Tex, and it's a little down and dirty, but the one thing you can always do is you can always give more. It's hard to take back. So if we load them in the litter and we haven't reached that pain threshold, then giving a little bit more, especially when you're dealing with IM in the backcountry, it's always okay to give more. Just something to consider for people who are spending more time in the backcountry but haven't really done it without IV access, which is often an issue back there. The other thing that I just wanted to bring up, and maybe Seth can speak to this, but there has been some discussion in debunking your blood pressure equals this, that, or whatever based on your radial, carotid, femoral, dorsalis pedis, and just something to be aware of, that it's not always equal to a blood pressure, but it may be at least greater than a certain blood pressure, if that makes sense. You'll often see in wilderness medicine literature these little cartoons showing the carotid pulse, and if it's a carotid, it's equal to this, and if it's a radial pulse, it's equal to that, and that information has been debunked. But if you know that it's greater than a set amount, that is the more accurate statement. Hopefully that said that clear enough.
There was a case when I was a resident of a patient who was, I can't remember her age. Let's just assume mid-90s, really, really kyphotic, like a nonverbal dementia. Of course, you put those patients in the hallway, which was where I saw the patient. And I had considered trying to put a rigid, like EMS style, non-padded collar on her, but I actually like held it up to her. I couldn't even figure out how to get it on her. And then my attending at the time, when I came to her saying like, hey, I couldn't figure out how to find this a properly sized one for her. But of course, the patient got taken away to CT by the time we got back to them and came back with like it was a type 2 DENS fracture, I think it was. And typical Detroit style attending resident interaction of getting screamed at for 5 minutes. And then turns out like nobody could get a collar on her, neurosurgery couldn't either. So just kind of remember that the goal is like managing the patient in the best way you can with what you got where you are with your resources, whatever it's pre-hospital, in hospital, wilderness, austere. The goal is to protect in what you can. And then the link, you can follow that to read further about what Pierce just mentioned. With that being said, like I said at the beginning of the session, this is the last of this series. Expect FOM credit certificates to come out in the next, give me about a couple weeks, and then we'll move forward with the next block. I'm going to end the recording at this time. Happy to join in with other conversations, but at this point, I think we've covered a lot. Thank you very much for our speakers, and then for Juan and Seth for joining in as well. Thank you.